Afternoon, everyone. Thanks so much for joining us today. We're really pleased to be able to host this 2026 Ontario post-budget webinar going through what we saw last week. We've had about 150 signups, so we're really pleased that you chose to spend your lunch hour with us. And we will be going through the Ontario budget today, picking out the health priorities and focusing on some of the trends, some of the insights, and we'll be drawing all of that out for you today with this amazing panel. Next slide, please. So, if you are a friend of Santis, you've been to one of our webinars before, you work with us, welcome back. We're really happy to have you here with us today. If you don't know who we are and you're meeting us for the first time, just wanted to share a little bit about us. So we are a proudly Canadian consulting firm that works across communications, management consulting, and government affairs. And we exclusively do work in the health and life sciences sectors. We have made a conscious decision to do that. We're a group of people who are mission driven and really want to see change in our health system. And we do that from coast to coast, all the way out from Halifax, here in Toronto, and out to Vancouver, reach across the country in terms of the work that we do in health with health organizations across the country. We've had the privilege of either serving as elected officials or serving as advisors within government. We've advised premiers, ministers, MPs across the political spectrum, and we've also served in the public service, advising on changes within the health system. So we've gathered today a bit of a panel who reflects some of the different perspectives in Ontario on some of these health changes. Next slide, please. So I'd like to introduce our panel today. So my name is Claire Michaels. I'm the Vice President of Ontario Government Affairs out of our Toronto office. My background is I was Premier Ford's Director of Strategic Communications through the pandemic. I also spent time at the Ministry of Finance shepherding budgets and full economic statements. So I'll be approaching things from that perspective today. I'm pleased to be joined by Catherine Brown, who is the former head of Health Shared Services Ontario, also served as an Assistant Deputy Minister in the Ministry of Health for a number of years, and she also led pandemic response for Ontario Health. Joining her as well is Robin Martin, who is the former Parliamentary Assistant to the Minister of Health. She also served as Parliamentary Assistant to the to the Treasury Board President, Caroline Mulroney, and she also served the constituents of Eglinton-Lawrence as their MPP. And last but not least, we have Michael Cecchi, who is our moderator today. He is a trusted public policy advisor for a Canadian law firm, Bennett Jones, and he previously served as as an advisor to the Federal Minister of Foreign Affairs. So that's your panel with us today, and we're really pleased that all of them could be here to help break down this budget for you. So before we start our presentation, I did want to go over some housekeeping items. So of course, at any time through our presentation, you may submit a question in the chat. There is a Q&A function at the bottom of your screen, and you can just type your question in there, and our moderators will review the questions and forward them to that part of the presentation. We will also have an email that will be going out after this webinar with a copy of the recording. So if there's anything that you missed, if there's points that you'd like to share with your colleagues, we'd really appreciate that. And that will be there for you after the presentation. And then last but not least, we will have a survey. So just taking a few minutes at the end of this webinar to fill out a survey on the presentation. Um, so in terms of what we propose to cover today, so I will be doing a bit of a presentation on the budget itself, just a refresher in the first 10 minutes on what we saw in the budget in terms of health spending, in terms of particular priorities. Then we will move to a moderated discussion on some of those priorities. And then at the end, we are hoping to take a few questions from the floor in case there's anything we didn't cover in those first two portions. So without further ado, I will dive into, if we could get into a time machine and go back 1 week, the release of the 2026 Ontario budget. Our initial impressions of this budget is really a budget that was focused on fiscal prudence and trying to take a balanced strategy. So, knowing that there are economic headwinds ahead with the CUSMA negotiations and with the U.S. trade tariff challenges, what can the government do with the revenues that it has? In order to protect itself, not just against those economic threats, but also protect core public services. We felt that this was a budget that really played it safe on healthcare. So it wasn't a budget that tried to ruffle too many feathers. It tried to manage public opinion risk. So, if we really felt the economic threat was high, we might have seen more restraint in spending. We might have seen even reductions in spending. But it was really a budget that decided to make some decisions on providing targeted funding as opposed to bolder structural reforms and really, again, protect those core services. And in those targeted funding priorities, focus on system stabilizers. So, looking at investments in primary care, hospitals, and home and community care specifically. Next slide, please. So here's a quick overview of some of the big ticket items that we saw in the Ontario budget. Again, a $3.4 billion new total commitment to primary care expansion, as well as a new electronic medical record platform. And we'll get into that a little bit later on in the presentation. More money for home and community care, a operating increase for hospitals, as well as some targeted spending in clinical placements for nurses. And then for long-term care, a smaller top up. So last fall, we saw a $1.9 billion investment in that particular sector to help stabilize and maintain the level of staffing that's required to deliver on the government's target, which was 4 hours of direct care per resident per day on average. So a smaller top up to help with those staffing commitments specifically. Next slide, please. So here's our quick snapshot in terms of what we saw with respect to health spending. I think many of the audience will know that healthcare spending is always the largest share of the Ontario budget. In the last few years, it's represented around 40% of the budget, and it is one of the most massive portfolios in the government. There's a lot going on in that, and a lot being targeted to different programs. We did see a $13.8 billion deficit for the next fiscal year projected. That's one of the higher deficits that's being projected, I think, out of many budgets that we've seen before. And again, that speaks to sort of the fiscal wiggle room that the government is looking for, knowing that it'll spend a little bit more to protect the economy this year. And then there is a new projected balance date, which is 2028 to 2029. And that's a date that keeps moving, but this is the new projected date for balance, which conveniently brings us to the next election. Some interesting dynamics there. If we look back at health spending growth over the last few decades, so since the 1990s, it's been about 5% average rate of growth. The reason our team was a little bit concerned about health spending projections in this budget is because in the fall economic statement, the projected increase for that particular portfolio was only 2%. Budget came out on Thursday, and we saw that that number was closer to 3.5%. So there was a bit of a projected spending increase over and above the full economic statement. Not as high as some sectors were expecting, but it's higher than 2% and sort of speaks to the fiscal restraint that Peter Bethlenfalvy, the finance minister, was projecting in advance of this budget. Next slide, please. Okay, so we'll dive a little bit more into some of the priorities of the budget. So another $325 million was allocated to primary care over the next few years. The bulk of that spending is for expansion, so for new and expanded interprofessional primary care teams. There's not a lot of new money for recruitment and retention in the existing network of primary care. So last year there was, in addition to the funding for expansion, there was some money, 149 million over 3 years for recruitment and retention in existing teams that was all targeted to non-physician allied health professionals. There was another ask that was brought to bear in this budget for closing that wage gap and continuing to invest in that. There were no new investments that we saw on that particular front. And then when it comes to the workforce pipeline for physicians, a parallel investment in these new primary care teaching clinics, there was an original commitment to about 16. We're seeing 18 as of the 2026 budget, and those are partnerships with various faculties of medicine across the province to encourage more doctors to choose family medicine as a career and help with this primary care expansion investment. Next slide, please. Home and community care, we would say, would be the big winner out of the fall economic statement and the budget. So there was a $1.1 billion commitment last fall, which was quite significant, and that was doubled down on in the budget that we saw on Thursday. Our understanding is that the bulk of this funding is being targeted to service delivery volumes. It is not being directed to the wage gap, but more about increasing the level of services being delivered in the communities. And that's in part being done through the hospital to home programs that are being delivered by various hospitals across the province. The government is reporting that they're seeing a reduction in the wait list for home care. Our team is doing a bunch of work to try to unpack that number a little bit in terms of, what is actually happening in terms of those wait lists going down, because we're still seeing wait lists going up for long-term care homes. So it's about 45,000 individuals who are still waiting for a long-term care bed. There are continued issues anecdotally around access. So we're doing some work around understanding what that means in terms of improvements in home care. Next slide, please. Hospital increases. So we would say another smaller win, just given what the finance minister was telegraphing ahead of the budget. So the hospitals did receive a 4% increase in this year's budget. It's consistent with previous budgets where that ranged from 3 to 4%. And so that's another $1.1 billion for the sector's operating expenses. The Ontario Hospital Association was out there and advocating last fall for closing that. There was a structural deficit of about $1 billion, and they were asking for 6% to close the gap. This past January, just given all the hospitals reporting in with their financial statements, they believe that number is closer to 2.7 to 2.8 billion dollars in terms of the structural deficit that hospitals are facing. Alongside these funding increases, there has been more accountability inserted into the system by Ontario Health and the Ministry of Health. There was put in place last year a multi-year stabilization plan for hospitals, given the amount of hospitals that were reporting a deficit. And we see this as a squeeze on the sector. So rather than reductions or outright cuts, not increasing funding to match sort of the pressures that hospitals are facing can squeeze them out a little bit and lead to reductions in perhaps other services. And we expect some of those trends to continue this year. Whether it's a hospital deciding, we're not going to keep our urgent care center open for longer hours or closing down temporary beds. There's some implications there around the increase in the funding alongside more accountability for that funding. And then a final point that we noted is really a capital slowdown. So there haven't been a lot of net new commitments in new capital builds, especially in this past budget. The number of projects that we're seeing and the number of beds that are being committed to hasn't really changed in the last couple of budgets. So there's about 50 projects out there committed to building 3,000 beds in Ontario's 10-year capital plan. The only number that's really been changing is that number of how much is going to be spent on these hospital capital projects. So curious to get into that with the panel a little bit later on, but capital slowdown is a real thing that we're seeing in this year's budget. Last but not least, health human resources. I won't spend a ton of time on this because I think we've seen it in primary care, we've seen it in home care. It continues to be a challenge. All I would say is that the government has been making some strategic moves in terms of opening up more seats. So whether it's physician assistants, nurses, medical lab techs, a number of health professions are seeing additional seats added and investment pouring in through the colleges and university sector. What's perhaps not matching that is the placement. So if there are a number of health institutions out there who are experiencing labor shortages, it's great that we are graduating more students in these health professions, but are there employers who can take these students and train them and ensure that those capacity pressures are relieved? So that's another one where we're watching closely. We're working with a number of organizations on that front, and want to continue to advocate for those clinical placements. Clinical placements for nurses, that's awesome. We want to see more of that happening in the system as well. All right, so we're on to the second part of what's happening in budget, and we're calling this bench strength because it's not just positive impacts or impacts on the health sector, but there are economic aspects to some of these investments as well. So digital health and artificial intelligence are good examples of that. I know everyone is eager to hear about the primary care medical record system that was just announced. We are in extremely early stages of the planning for this platform, but what we do know is that Supply Ontario is leading the market sounding, and the market sounding is really about understanding who are the players in the space, who can actually deliver on this work, who has the technology and the expertise to be able to do it. Can we create an integrated system? Can it be interoperable with the dozens of EMRs that already exist, electronic medical record technologies out there that already exist? So that will be part of shaping it in terms of who can actually do this and what are the criteria that we need for that particular platform. Um, the government has said that they will be going to a competitive procurement process, and Minister Jones has also said that this initiative will be voluntary for physicians, so they won't be mandated to adopt this particular platform. Um, and again, just because we've received this question a number of times, but there is no anticipated cost released yet for that EMR. The 3.4 billion that was announced in the budget that does not take into account this investment. So we anticipate funding for this particular initiative will come later down the road once they understand the shape of what they're trying to build. Um, and then another point of interest, and more on the private sector side, but the Ontario government is taking a look at building a new AI industrial strategy. So looking at how to empower artificial intelligence firms in Ontario, so supporting homegrown innovation, and then also supporting its adoption at home to help turbocharge our economy and address some of the productivity gap that we're seeing. The Ministry of Economic Development and Invest Ontario has said repeatedly digital health is one of the priorities and one of the clear use cases for artificial intelligence. So we'll be following this with interest, and that strategy is set to be released this summer. Next slide, please. Life sciences, another big winner in this budget. So a number of initiatives, a number of mentions throughout the budget of how critical this particular sector is to Ontario. The biggest ticket item out of the entire budget was this new $4 billion Protect Ontario account investment fund that will be specifically targeted at strategic sectors and life sciences, defense, artificial intelligence, critical minerals. All of those sectors will be eligible for this fund. If you'll recall, last year there was a commitment to a Protect Ontario fund that was in the neighborhood of $5 billion. And that was dedicated specifically to tariff relief and helping workers and businesses. The government has decided this year to carve out some of that fund. So $1 billion will still be set aside for tariff relief, but they're going to be using some of this money to be more strategic in attracting and retaining investment in Ontario. And to manage this fund, they are on the lookout for an investment manager who can identify that pipeline, attract some investment from pension funds and investors, and help turbocharge that growth. And then there's some smaller commitments in the budget for not-for-profits and small and medium-sized enterprises. There was the life sciences strategy that Ontario released a few years ago. The Life Sciences Scale Up Fund is part of that, and there's a renewed commitment to continue investing in that part of the strategy to help with some of the smaller firms who are playing in this space. Next slide, please. So I did want to spend a little bit of time, and I think this is our last slide before we get into the discussion. But by Ontario, it is another issue that we're watching very carefully and seeing where the government is positioning. In its initial public communications, it was clear to us that they were targeting goods, so specifically around procurement of vehicles for the government fleet, specifically around construction materials trying to buy to use the government's $200 billion procurement power to try to nearshore some manufacturing, try to support Ontario-based businesses. We're now seeing that that could potentially impact a much wider set of goods that could include medical supplies and other aspects of the health sector. So the current state of play with respect to health procurement is that Mohawk Medbuy Corporation is managing a lot of the medical supply procurement in Ontario, and Ontario Health and Supply Ontario are doing everything else. But they are sticking very stringently to that order of priority that was set out in the Buy Ontario Act, which is, if you're applying to be a vendor of record, if you're applying for an RFP, you get more points if you're an Ontario company. So you're number one on that list in terms of trying to prioritize those businesses. Then comes Canada, then comes everyone else. So that has implications for how organizations are thinking about doing business in Ontario, how they're procuring. And we're already seeing some of the penalties being rolled out if you aren't prioritizing in that way, which could include, holdbacks, vendor performance management measures, and even barring vendors from future opportunities. We're not aware of any health vendor being barred at this point, but we are hearing a lot about the challenges in terms of dealing with broader public sector organizations with their procurement processes. And the US procurement restriction policy has a lot to do with that as well. So I think that brings us to the end of the overview. Just some things to think about. So spending is increasing over successive budgets, but a key question to ask is the system capacity increasing as well? When we look at wait times, when we look at bed capacity, and when we look at existing models, are they working? Is anything changing due to these reforms, due to the additional spending in the system? And I think everyone can agree that ending data silos in healthcare is long overdue. But can we get it right this time? What's changed in the last few years in terms of what's possible? And are we thinking about things like cybersecurity? Are we thinking about things like data sovereignty and interoperability, which has been talked about for a very long time, but more importantly, building trust into the system and what that looks like. And then last but not least, I think we can all agree that it's a good thing that, more jobs, more opportunity, more businesses will relocate into Ontario because of the Buy Ontario policy. But what are the unintended consequences of that? Are we actually seeing increase in health system resilience if we're trying to nearshore that manufacturing? What will it mean in terms of procurement costs? What will it mean in terms of our relationship with other countries and global supply chains? And what will it mean for intellectual property, especially as we head into a year of CUSMA negotiations? So lots to think about. And I think at this point, I'll turn it over to Michael Chechi to kick us off and help have a bit of a guided discussion about some of these priorities.
Thank you very much, Claire. And that was a great discussion through the budget. I feel very fortunate to be able to work with Claire as a senior advisor for the Santis team. Not only does she get the political nuance, but she is whip smart on the policy side. So thank you very much for that, Claire. So we're going to move into some questions. We have some that have already been submitted, and then we're also going to be taking some of the questions from the floor. But let me start off on the financial side of things. I mean, the budget has delivered about just over 1 billion. I think it's 1.1 billion in new hospital funding for 26-27. However, a few months before the budget was out, I believe the Ontario Hospital Association president had indicated that the sector needed about 2.7 to 2.8 billion just to stabilize. So I think I'm going to throw it over to sort of Robin, who's been there with the Ministry of Health when they're getting these budgets together. From your vantage point, what does this gap mean in practical terms for patient care over the next 12 months?
Thanks very much, Michael. And I just want to start by saying thank you to Santis and Claire and you, Michael, for having myself here as part of this discussion. I'm looking forward to it and looking forward to hearing Catherine's thoughts as well, as I know she has a lot to give us here on this call. It's a very, very difficult time to make a budget. Budgets are always difficult. Healthcare budgets are always difficult. But we have to recognize the context. We've got a lot of international factors which are really creating uncertainty for financial projections, even more uncertainty than we would normally have, particularly what's going to happen with tariffs and CUSMA, which is important to Ontario's economy, which is so linked to the United States. There's the Middle East war and oil prices going up quite a lot, which obviously is going to impact costs. And revenues, I think, were stable or down a little in this budget, which the government's trying to help a bit with by giving the small business tax break. But it is always a challenge, obviously. So what I see the government doing, and the word that I kept reading in the budget was prudent, prudent, prudent. And the minister stressed that this context, it makes things difficult. And I think they picked the projections that were mid-range for how the economy will do. But they have a pattern in any event of leaving some fiscal room. And here they have left fiscal room specifically for flexibility. So they've got, I think, a $1.5 billion contingency and reserve, which increases a bit over the years projected. And they've done that before. So I think what they're doing is saying, we need to be prudent. We're going to stay the course on the things that we've got to stay the course on that Claire went over, things that we've committed to. But we know that it's a difficult circumstance and we need to preserve some fiscal room so that we can adapt.
That's great. Catherine, do you have any thoughts on that?
Sure. And thanks and good afternoon, everyone. And thank you to Santis for having me today. I would echo what Robin has said about certainly the environment that we're in. It has been a tough few years for government. And we have a challenging few years ahead of us. I think, the system has not recovered fully from COVID, so that legacy lingers. This past year alone was extremely challenging for hospitals in Ontario through the flu season. They saw some of the toughest wait times and backlogs that they've seen in recent memory. I think, I agree with Robin that the budget is measured and prudent, but it still has an impact. Even when there is no room to give more, it still has an impact on patient care. And I think for those hospitals in Ontario, hospitals in Ontario have the lowest per capita funding of any hospital in the country. They are lean. They have been working hard to stay lean. So those challenges then come to where do they find efficiencies? And I think the positioning around multi-year stabilization and the focus on accountability is important, but it's also important to let hospitals do what they do best and let them manage patient care. The challenges of health human resource access and vacancies in smaller communities, it's tough. In large communities, it's tough. So that leaves hospitals having to cut in some of the places that they don't want to. So leaving vacancies for longer or not expanding necessary programs. I think they will manage, but those structural deficits will continue to grow and won't go away. So there's going to need to be a balance between how that accountability for stabilization is put into effect and how we give hospitals the flexibility where they are managing in an accountable and appropriate fashion to do what they do best and manage patient care in the interests of good patient care. I'd say
Thank you.
one other thing, and that is to say they have been acting for years as a backstop for the system. So they continue to be the backstop for long-term care and home care. And when we can't move those patients out to other parts of the system, that becomes an ongoing problem for them and a cost for them. So it's another important aspect to remember as we look at the system overall. Sorry,
Okay.
Michael.
So we've talked about operational funding now. The budget also includes a 10-year, $64 billion health infrastructure plan with about 50 hospital projects and over 3,000 new beds. The Ontario Nursing Association has raised the concern of what they call unstaffed beds. And so how do we ensure this capital investment translates into, I guess, operational capacity and not just ribbon cuttings? And Claire, I'll throw that question to you, just sort of being there. Obviously it's much easier politically to announce large funding for capital, but how do we balance the needs of capital and operating?
Yeah, I think so. What I'll do is I'll probably approach that from the construction angle, and I'm sure Catherine and Robin have perspectives on how to get at it. But if I could articulate the challenge around getting some of these projects built, they are multi-year and multi-decade processes in many cases. It takes a long time to build a hospital in Ontario. Cortellucci Hospital, as far as I know, is the first net new hospital in all of Ontario. And there's a reason for that. There's, I believe, only two construction companies in the entire province that can deliver on some of these redevelopment projects at that scale. So that presents challenges. And I think we've seen the government try to pivot, in the last few years to seeing if modular builds, smaller construction companies, standardization of builds can help, diversify the number of companies that can build these projects, in pieces, so that they get up and running faster. And it's not just waiting on these two larger companies to try to build these projects because then, they're also competing with highways and transit and getting all those other projects built. And so the challenge with hospitals is acute, and I would say that getting the existing pipeline of hospitals built it should be the priority in trying to get some of these done within a reasonable amount of time, and whether that's looking at modular builds or looking at involving more companies, I think that could help relieve some of the pressures.
Catherine or Robin, any insights into this?
I'd just add, I agree with Claire. I would just add that I think there's no value in delaying infrastructure improvements, and they are critical to hospitals maintaining capacity and letting them linger. We heard in Claire's overview, there weren't new investments. And so we need to think about not letting those languish in the interests of the longer term. As Claire said, these projects are never quick. And so as it relates to staffing for beds, that is something that it will be important, but it's 5 or 10 years down the horizon once these projects are built. And it's something that we need to keep moving forward in order to have a modern and efficient healthcare system. So I would just echo the push on that needs to continue as much as possible.
Yeah, and let me just add, I think that it's good that there aren't any new projects, because when you have so many priorities, it's hard to make sure you get anything done. And I would like to see them get some of these done. And I think that's a better focus than adding yet more priorities. But I do believe that the government will always be there for hospitals, even though right now it looks like they're being prudent with what they've given in the budget. In fact, the Minister of Finance said that we've always been there for hospitals in discussing the budget, and I believe he meant it. We will be there, and in my view, there's no way that the government would ever build the beds and then not staff them. They would find some way to make that happen. And as we've said, it's much further down the road probably, and so not an immediate issue. But I do think that it's important that we focus on getting the things done that we can, and realize that the government is putting in some contingencies and reserves, which in past budgets it has, used. By the end of the year, it has spent more than was budgeted or planned. So I believe it will do that again, because past behavior is the best prediction of future behavior.
Great. Thank you very much. Now, most people in the province, they sort of experience healthcare at their local family doctor level. So let's talk about primary care, and the primary care action plan is now totaling about 3.4 billion over 4 years, and that's with a goal of connecting, I think, every Ontarian to a provider by I think it's 2029. So the government reports in what they call the Healthcare Connect waitlist that has been reduced by 87% as of March 2026. And how much confidence, and perhaps I'll throw this to Robin, should we have that these numbers reflect a genuine, sustained attachment to ongoing care?
Thank you, Michael. I mean, it's kind of a moving target anyway, as people come on and off that wait list. There will be people who have been attached to primary care. There's certainly an effort happening to make it so. But there will be more people who need attachment to primary care as time progresses. It won't necessarily be the same people, but it's going to happen. One of the issues that I was always concerned about when I was at the ministry was it's the transitions. So a lot of people who are aging, like myself, they get to a certain point and their family doctor is also at retirement age. And that's often a place where they start to need for sure to have a family doctor who knows their history, etc., and who can be there for them. And those transitions are, I think, where the primary care system should be focusing, especially for older patients. There's another transition for younger patients, maybe when they settle down to work after they've come out of university. But a lot of young people aren't that interested in having a primary care doctor. They don't necessarily need to be attached unless they have particular health issues that are driving their seeing their primary care doctor. If they're otherwise healthy, they're not going to be worried about it until about the time they start to settle down and think about future plans and children and things like that. So the elderly population without family doctors, that I think is a big issue, and I think where the system should focus for meaningful change.
Catherine or Claire, anything to add on that?
I would echo what Robin has said, and I think that to your question, how real are the numbers? I think it is a moving target, and we have seen certainly a reduction in the wait list, but the need is great. And in smaller communities across this province, the recruitment of physicians, nurse practitioner funding, all of those aspects make it very challenging to get physicians into communities and get those wait lists cleared. And as Robin has stated, the need for aging Ontarians to have primary care where they are when they need it is growing by the day. And that is where we're seeing the greatest gap locally and where we're seeing people really have challenges throughout Ontario in getting that primary care access. So certainly the push on primary care has made a big difference, and it's good to keep that focus and to continue to try and bring down that wait list through Healthcare Connects. It's not the only place that people go to get a primary care physician, so it's also important to remember there are other avenues for doing that people access just through word of mouth or other things. So those lists will continue to be pressure points for some time. Adding some additional resources and focus to how that recruitment is happening and how we, for example, expedite the work on nurse practitioner funding so that they can be in place in communities and helping to support the gap in primary care will be important to really help expand access across the province.
Okay, great.
And I do want to just on primary care. So 88% of Ontarians are attached to a primary care provider or primary care team at this point. So we're looking at 12% of the population. There are probably people in that group who genuinely cannot find a family doctor, who may have frustrations, in terms of, they are attached, but, getting an appointment with their family doctor takes 4 weeks, to actually get something with them. So the meaning of that attachment needs to be looked at as well. But in the rest of the population, you're looking at attaching some of the hardest people to attach, frankly, because they haven't found a family care provider, and thinking about the mental health and addiction space and the work that CMHA Ontario is doing to try to get those folks attached. But they are vulnerable populations. And so we're looking at attaching some of the most complex people in Ontario to attach to a primary care provider. And the incentive, yes, it's helpful to say, we need to hit attachment targets, but what else is there to that in terms of making sure that these people, can get a next day appointment, can get, the level of care for their chronic condition or whatever it may be. So lots to think about. Attachment is one metric, but there are probably other things that need to be thought about.
Thank you, Claire. And just a reminder to our audience, please feel free to ask one of your own questions using the Q&A button at the bottom of your screen. I see a few are trickling in, and we have one about sort of this new proposed EMR. So I think just to sort of build on this question, but the budget is talking about a big digital modification effort through a primary care medical record system that is aiming to replace, as you know, thousands of isolated chart systems that don't speak to one another, that are on paper or in triplicate and carbon copies, with an interoperable platform. We know we've gone down this road before with different large procurement and the issues that come with them, thinking of e-health, of course. What are the biggest implementation risks, and how should these procurements be sort of structured to learn from past problems? And I'll throw that one to Catherine.
Thanks, Michael. Not an easy question. I think that the biggest challenge is timing. As the wording is very clear in the budget, these initiatives will be voluntary. They want them to be interoperable. That means people will have to figure out how to come onto these systems themselves. Over the years, physician groups, individual physicians, primary care generally has invested in their own systems because they needed to. So whatever work the province is doing on the primary care EMR needs to be fast and efficient. It needs to be focused. They need to utilize both the expertise that they can find in primary care on what the best and most necessary aspects of that record need to be in order for it to be interoperable, but they also need to access experts in digital records to help understand how they can develop a procurement that is efficient and fast. And sometimes government doesn't move as quickly as we would like. And so as we know, technology does move quickly, and we are seeing with AI and other things that technology is moving more rapidly than ever before. And so the ability to do a needs assessment and understand what that record should look like at the same time they're building what they need and then getting that procurement out and done will be critical and important to get people to volunteer for it. It will have to be of a quality that they can trust and that they believe will support their needs.
And how does any sort of a voluntary system make sense in this type of scale? I don't know, Claire, Robin, or Catherine, that question is for anyone.
Well, I think that is, as Catherine was saying, it's another factor to consider, maybe another challenge, and it often is problematic. And I think the government said in the budget that it would look at funding, transitions to this new EMR for various primary care. I mean, the truth is that the primary care reform absolutely needs the EMR. And it needs an EMR that can talk to the rest of the system. And a lot of the changes that the government's talking about are about integrating our system, not just across primary care and hospitals, but for home care and community care, and making sure we don't redo tests and have patients repeating, their history to everybody. It's all the right objective. It's just getting there is really hard, I think, for government, and we haven't, seen a lot of success in this so far. I'm hopeful that the Ontario Health team integration is going to help with that. They certainly need to do it to make the primary care reforms work. And so I guess we're keeping our fingers crossed and hoping we've got the right people with the emphasis on interoperability, because it has to be interoperable and it has to be easier for the healthcare providers in the primary care teams to use. So they don't have to go out of one system and into another to get the lab results, etc. And that is critical, I think.
Mm-hmm.
If I can
we
add,
go ahead, Catherine.
Just add quickly, I think one of the other things that Robin highlighted That record is also an extraordinary source of data in how we build and manage the system going forward. And our inability to capture it in a holistic way, that we can only capture it piecemeal and anecdotally, as Claire mentioned in her presentation, really limits the province's ability to cast the future and look at how they might do things differently. So the sooner we have that ability, not just to manage better patient care, but also to capture that data in a more efficient way, to be able to use it for the future, the sooner we can do that, the better.
Mhm. I'd like to move into home care and just have a quick discussion there. So the government claims to be clearing, I think Claire, you said 94% of home care wait lists, yet we're sort of still hearing about various challenges with access. And an Ontario Home Giver Association report from, I believe, last December stated that about 1 in 5 caregivers were dropping loved ones at the emergency room just to get their own personal break, which is obviously not great. Will increasing service volumes help to address those challenges?
Want me to start, or Robin, did you want to?
Sure, Catherine. Yeah.
This is a tricky one. I think the investment, certainly, as Claire mentioned, is significant. It has been significant for the last couple of years. There was $2 billion in 2024 over 3 years, and then in the fall economic statement again now. I think the challenge is seeing a measurable improvement in how access is being provided. And to your point, we still see the caregiver burnout. We still see areas of the province that cannot get care in the way that they need it. And numerous issues with how the home care system operates. There was subtle wording in the budget about the government engaging with stakeholders to transform home care. And I think that is an important aspect of this, to really, we haven't done anything to really significantly transform a very old form and method of providing home care. And so looking at how we might do that better and differently, and do it efficiently, not spending a lot of time trying to reinvent the wheel, but really working on how we can build a better system, I think will be critical. It is really hard to tell whether the dollars are going where they're needed or if they're going to increased volumes. Certainly that is happening, but there's still a gap, and we see those ALC numbers remain, not just for long-term care, as one of the listeners had indicated in the questions, but also for home care. And hospital to home was created to try and alleviate some of that backlog. So I think the more we can do to really hone in on a streamlined and coordinated home care system will really help to make those investments bear fruit.
Mhm. And I don't know, Claire, if you have any insights, or Robin, from where you sat when you were both in the government, but what is sort of the relation between home care and community care? And I know home care has been called out. Is community care considered part of that? How does that sort of play into things?
I would say, up till a few years ago, the difference between home and community care was not well understood. And both of them really need to work together to help that person be able to age in the comfort of their own home, which is what we want for most people and we want for our loved ones. And so thinking about what needs to be in place to be able to help them. So it's not just sort of the home care supports at home, the PSW, the nurse, but services such as transportation, meals, all of that is important to the well-being of the person, and reducing that social isolation, making sure that they're being checked up on. So that is all important, and my understanding is that there is a portion of this budget that's being devoted to the community care piece, and that typically would not have been there in the past. And there were certainly supports awarded during the pandemic to community support services, recognizing that need. Could it be better? Yes, of course, always. There are some interesting things that home care organizations and community care organizations are doing across the province. Whether it's centralized registries, so it's easier for someone looking for home care to find that support and find that support easier for them. They're culturally appropriate services. So I'm thinking about someone like my grandmother, if she's not eating the food that she grew up with, she's not going to eat it. So you want to make
Mm.
sure that there's appropriate care in that way. So I think we're getting better at it, but there needs to be a better understanding of how home care and community care work together to keep that person at home.
Robin, any thoughts there?
Well, I do have thoughts. I think it's mostly been said, but I guess one thing I would say is we learned during COVID that although the hospitals, as Catherine pointed out, are the backstop of our healthcare system in so many ways, and a backstop for
Mm,
home care and a backstop for long-term care, they can't do everything, especially if we're facing a virulent infection like COVID-19 was. Even hospital CEOs agreed at the time that we need to move things that shouldn't be in hospital out of hospital. And I think the government is trying to do that, but there's always a tug of war to keep, providing the services that you need to make sure people are getting the care they need, when they need it, where they need it, and to also build the parts of the system that can take some of the pressure off the hospitals, off the emergency rooms. And so the focus on primary care and home care and community care in the budget, and long-term care as well, and the builds and things like that, those are all part of, I think, trying to invest in a transformation of the system so it's not so dependent on the hospitals and the emergency rooms, which are struggling.
okay. Um, I'd like to sort of discuss the federal and provincial interplay. So Ontario, with all the other provinces, basically is calling on Ottawa to make permanent this temporary 5% minimum growth rate guarantee for the Canada Health Transfer. That expires in fiscal year 27-28. And so the budget makes it clear that provincial health investments have far outpaced the increases in the federal health funding, from sort of those large cuts in the 90s. What is the realistic political path to a renewed federal commitment, and what happens to Ontario's health system if that does not materialize?
I won't comment on the political path. I'll let Robin speak to that. But I will say, the federal-provincial relationship for healthcare has always been a challenging one. And I think, as we said at the outset, and as Robin described at the outset of her remarks, this is a very, very challenging time for governments around the world, as it relates to the economy, what's happening in instability and predictability. So I think, pressure will need to continue to be brought to bear, and I'll leave it to Robin to speak to that more directly. But the challenges for all of us in the coming years will continue to be need careful thought as we look at what's happening around us as it relates to the other things that are affecting our environment and affecting our economy so dramatically.
Claire, what do you think the political angle is, or Robin, as the two sort of people that have either run campaigns or been a candidate and gotten elected?
So this was an issue that I actively worked on in Premier's office, with colleagues, provincial colleagues across the country, and time and again it did come up. I'm sure if we stretch our memories back, this used to be a 50-50 deal where, the federal government on Medicare was supposed to cover 50% and the provinces cover 50. Today, it's closer to 75-25, where the provinces are picking up the bulk of that slack in terms of funding these services. And so I think there is perhaps a fair and reasonable effort to try to increase that share of total cost. So I think when I was involved, the ask was 35%. I wouldn't be surprised if that comes forward again this summer. But there will be some sort of in between negotiations, and I know Carney has his own constraints on the federal budgets, but he will hear loud and clear from the premiers that this is a priority, and that I can't imagine Premier Ford as the chair of COF not asking for something like this, because it impacts so many people in so many ways.
Yeah, and I wouldn't add much to what Claire said, except to say that I think it should be part of what the Council of the Federation discusses, and it should come to the federal government. Maybe, ad campaigns, etc., could be helpful. It could be an issue in an upcoming federal election. Unfortunately, there are so many other big issues competing for attention. Healthcare is usually a very important issue to most people, but when the fate of the economy is resting in the balance, and there are wars internationally, it tends to also get pushed aside. So I think there are some really important discussions to be had. We need the federal government, which takes a bulk of the taxes, to make sure that they're standing there for the healthcare system, which is the biggest expense every province has. And especially at this time with our population growing, aging, increasingly complex, and with us trying to affect system transformation.
Mm, okay. I see that we're getting sort of towards the end here, and so I would be remiss if I didn't ask what I think is one of my favorite questions that has been received. But looking ahead, whether it's 5 or 10 years, and given the constant sort of fiscal constraints, whether it's a good budget or a bad budget from sort of a stakeholder perspective, there's a constant fiscal constraint there, and we have an aging population. We have trade uncertainty that everyone is well aware of. So, what is one structural and major reform? And we're gonna go to each of the panelists that this panel would recommend to sort of put Ontario's health system on a sustainable footing, because it seems like new money is just not going to sort of cut it in the future reality that we're in.
Maybe I'll go first and
Sure, Claire.
just break the ice. But I truly believe, just with the generational changes that we're seeing, that patients will want more control over the care they receive, when they receive it, how they receive it. So whether it's going to a screen and talking to somebody on it and trying to get care in that manner, going to their pharmacist, going to the hospital. I've heard it anecdotally lately is like the least amount of time that patient can interact with the health care system, that is good for the patient. That's what the patient wants. And so, how are we structuring the system in a way that the patient gets what they need out of it, and it's more responsive to what they need, as opposed to us trying to centrally plan that and dictate how it should be structured.
Okay. Catherine or Robin, do you have any big sort of thing that would sort of blow the system apart and make it more effective to work for more people with the same or less amount of money?
Don't know whether I have that magic wand, but I would build on what Claire was saying. I think, to make those systems more efficient and make the collaboration across systems work better, I would say one of the things, we learned a lot during COVID. And one of the things we learned was that we could make decisions quickly and efficiently and make good choices. And we did that because lives were at stake. And so government became very lean, became very efficient, became very interactive, as did communities. And I think if we can find a way to put that back into the system, have government enable decision making across communities, enable that building between entities across the system, determine how to make that move forward more efficiently and more effectively, that would go a long way to improving the access across the system. The slowness in decision making has always been and will continue to be the thing that crumbles the process as we go forward. And the sooner we can find a way to make better decisions faster and enable the people on the ground who know how to do it best to do it, that will make a huge difference in access to care for patients across the province.
Robin.
Well, I'm not sure I can add much to that, but I think both Catherine and Claire, are on the right track there. I think, I would like to see some stick-to-itness, some perseverance on the objectives that we've set out. I think that this government has listened to the experts about what we need to do to fix the system, which is in part to not be so dependent on our hospitals as the backstop for the entire system. It needs to stick to those goals. It needs to stick to making primary care an integrated part of the system, home care an integrated part of the system, long-term care. So all of those things need to happen. And I think if they did happen, it might take us some time to see how these reforms are going to play out. And it's hard for government to not have the results immediately. But I think they need to stick to it. And I'm hoping that if there was ever a change in government down the road in Ontario, new governments would also stick to those goals, because I think those are the goals the experts have said this is how we fix our system. always going to be things we need to change, but I think we need to fix the system, and I think everybody wants the same thing: better healthcare centered on patients.
Very good. Well, I would like to thank everyone for joining us today. Thank you very much for the questions from the floor and for those that submitted questions in advance. I'd like to thank our three great panelists. Thank you, Robin. Thank you, Catherine. And thank you, Claire, for your great presentation. For any of you that have further questions about what was discussed today or want to discuss further on the budget, please reach out to us at the Santis team here. We would be more than pleased to have a conversation with you and see how we can assist with any of your healthcare related needs. So I'd like to wish everyone a great day and have a very happy long weekend coming up. All the very best.
Thanks.